Welcome back, my Be Health Empowered family. Welcome to another episode of Excuse Me, Doctor. My name is Dr. Melissa Clark. Of course, please call me Dr. Mel. Happy as always to be back here with you for another amazing week that we are going to create for ourselves with the important health news and health information that we have to share. And we're here mainly for you to make sure that you have the information that you need to make wise health decisions, not just for yourself, but for your family, for your loved ones, and even for your community. So, we are going to get right into it. I want to welcome my newbies. And for those of you who have not yet hit that like button, if you are on YouTube, or sorry, if you're on Facebook, or hit that subscribe button if you're on YouTube, now is a fantastic time to do that. And we really appreciate you for it. And of course, my Be Health Empowered family, I know y'all are waiting for me to bring in my two amazing co-hosts, Mr. Wayne Bruce and Miss Lila Mays.
Fantastic. Wonderful. How you, Dr. Mel? How you go on mute? Hold on.
I don't know.
How did you go on mute? What happened?
Magic. Am I still muted?
Magic.
No, we hear you, Dr. Mel.
We hear you.
Okay, good.
You were talking and gesturing.
Yeah, I mean, I don't think I hit anything. I was just about to say, the summer is over. We're in the fall. This is my favorite month of the year, so I am super excited to be here.
Is this your favorite month?
Yeah, September is my favorite
month.
September is my favorite month.
Wow.
Yeah.
Things you find out on Dr. Mel's show.
I'm telling you. What's y'all's favorite month?
November.
I wonder why.
I know. I wonder why. Well, that actually dovetails beautifully into what we're talking about tonight, because what's going on in November that relates to this show?
The election is happening. My birthday and Turkey Day.
It's a lot going on. It's November.
It's a lot, but we're going to talk about the ballot. We're going to talk about your health is on the ballot. We watched the debate together, the three of us, and we thought it would make a lot of sense to discuss health related issues that are on the ballot. So that's what we're going to do today.
Yeah, because in the debate they only really got into like one health related issue at the very end, but there's a whole slew of health related issues. And we have an incredible guest, Dr. Lindi Randall-Hayes, that is going to walk us through it and break it down for us so that when you go into that ballot box, what are some of the issues and the implications of your vote when it comes to your health care, and the health of your community. So
I'm excited.
Hang in there. We're going to get to it.
Come on, bring Dr. Lindi on.
All right.
But before we bring Dr. Lindi on,
yes,
let's recap the week that was in health and wellness.
All right, let's get that weekly recap going. All right.
We need music for the recap.
We do.
We need a recap theme.
We need recap fire music.
Let's do a little song in my head.
I'm thinking, okay. I don't know. I was thinking more like Shaft.
Oh, we can't afford to pay for Shaft.
Right.
Fortunately, we know lots of musicians. Anywho.
Exactly.
Number one, are tampons endangering our health? Millions of women use tampons. Dr. Mel, what are some of the possible health risks, and are they serious?
Well, we talked about this actually a few months back when the study came out that showed that tampons contained metals like arsenic and lead. But the reason we're mentioning it again tonight is the FDA has finally said, hey, we need to study this and figure out, is there a link between these metals in the tampons and possible health effects?
Okay. So what might the FDA do if we find that there are some health risks related to these metals?
Well, the possible health risks, let's start there,
Yeah.
are these metals at high levels can be associated with damage to the nervous system, the kidney, um, dementia, infertility, diabetes, cancer, and harm to other potential organs and organ systems. So, given how widespread they're used, how much tampons are used, you could see potential regulatory changes, recalls, new safety standards. All those are within the FDA's, um, purview if they do indeed find that there is a connection between tampon use and, um, you know, risks to your health.
Yeah.
Yeah.
Like that's kind
And
of
in the meantime, if people are like, oh my God, I got to stop using tampons, we're not necessarily saying that. But if you do want to look for a tampon alternative, there are a ton of them. They're what our parents and what our grandparents and great grandparents used to use, reusable cloths, right? There are also menstrual discs and cups, as well as sea sponges. So all of these are products that are on the market that are right now that are alternatives if you want to switch to something different.
Yep.
It's tough for for a man to weigh in on this, but I
Uh-huh.
would say this, that it is very important that we keep an eye on this, because we have daughters and wives.
Hmm.
So men, we want to be aware of this situation at all times. So
Thank
that's
you for
important.
that.
Agreed. Yes.
Well
I
said.
mean,
Well said.
I am who I am, right? So anyway, let me get out of y'all space because I'm not in that space. But I want to talk about this COVID-19 and updated vaccines, Dr. Mel.
Yeah, and it's just in time because they're actually new strains of COVID. They just announced the XCC um, strain that's in Europe right now and hasn't really got here, and is of course going to be as contagious or potentially more contagious than the variants we've already had.
Wow.
So the news is that the FDA has authorized updated COVID vaccines that happened a couple weeks ago from Pfizer and Moderna. They're now available. You're probably getting texts or whatever from your local pharmacy. You can get them from your doctors, a variety of different places. But they're available now for you to go get your COVID booster and your flu shot while
Mhm.
you're at it if you want to get them
Right.
both at the same time. That's been proven to be safe.
I got mine 2 weeks ago at my local pharmacy, and I
Same.
know I know the virus is always changing. So I just want to remind everyone that the antibodies you made before last time you got COVID or had a vaccine booster probably won't serve you, right, Dr. Mel, in this new season.
Correct, because of that variant and other variants that I mentioned that are already out. I got
Mhm.
mine too a couple weeks ago because I know winter is coming,
Mhm.
right? So, and we know that with winter, we get that triple demic,
Mhm.
COVID, flu, and especially for the very little ones and people over 65, RSV.
Mhm.
So very important to prepare each and every winter because
Mhm.
at least now for the foreseeable future, those viruses always resurge.
Mhm.
Starting mid to late October on through the winter time.
Wow. Yeah. So what about paying for them? I mean, like I know we're talking about healthcare and how it affects government and on the ballot. What about who pays for them now?
So yeah, it used to be that the federal government was subsidizing the cost, so they were basically free. But now with the the federal emergency ending around COVID that ended last year, these vaccines are no longer free. And if you're paying out of pocket, you might be paying up to $200. However, if cost is an issue, meaning you're not insured and your insurance is not picking it up, you can contact your local health department to figure out where you can go to get free
Yep.
vaccines, or you can go to a federally qualified health center, also called a free clinic,
Yep.
and they also will have vaccines available either for free or on a sliding scale. So all is not lost.
Yeah, I
Wow.
did some recon for some friends a couple of weeks ago who went and tried to get the COVID booster and the flu shot, and it was over $300 for both of them out of pocket. Yeah.
Wow.
Mhm.
Mhm.
Yep. And what were you
300.
able to find?
Some like of clinics around the city, and there were some places that were
Yeah.
offering them for free. Yep.
Fantastic. Fantastic.
Mhm.
Wow. Wow.
Good to
So
know.
so I just want everybody to know, go get, even if you don't have it, just go get your booster. And there's a I want to stop. Well, I don't want to stop. I want to continue. There's a question saying, is it safe to get the flu shot and the booster at the same time? T
Yes.
Barnes
Yes.
asked. So we want to make
Yes,
sure
it is.
T Barnes knows that. Okay, T Barnes, you got that?
We did
So,
T Barnes. I got both of them at the same
yep,
time, and
yep. Dr. Mel did too. And
mhm.
I'm the
Actually,
only
Dr.
one that
Mel did
did.
not.
You
Dr. Mel
didn't?
did not. No, I only got the COVID. And I'm gonna get the flu probably in the next week or two.
Okay. All
Yeah, I
right.
decided to space them out, but that's not that's not necessarily actually, honestly, the reason why was because I was going on a trip overseas, and I just wanted to give my body one thing to deal with at a time, given that I
Right.
was traveling, I was gonna have jet lag and all of that. But
Yeah.
it is perfectly safe to do them both at the same time.
Wow. And
Yeah.
there you have it.
There you
Mhm.
have it.
There you have it.
Um, all right. Well, moving on to these flaming hot Cheetos. Listen, in complete transparency, I have enjoyed a flaming hot Cheeto or two in my day. I'm gonna just keep it all the way funky. Been a little while, but I like them.
Okay.
But my my home state, California, is
Mhm.
cracking down on foods like flaming hot Cheetos and other snacks that contain these artificial dyes. What's the deal with them, Dr. Mill?
So, I like Cheetos. I don't like the Flamin' Hots, but they're equally full of red dye number 3,
Yeah.
which has been linked to hyperactivity in children and also maybe cancer causing. The
Mm.
jury's out on that, but the possibility is there. So it's part of California's sort of larger effort to eliminate the use of harmful chemicals rather, in food. And if this legislation passes, California will be the first US state to ban these kinds of chemicals. California is often a leader in these sort of environmental and nutritional issues. And our neighbors over in Europe have already done it. The EU has already prohibited the use of several artificial dyes in food. So even though California would be out front for the United States, not out front for the world.
Right. Well, hopefully this move will make these large snack companies change the ingredients they're using in our foods, and everybody can really be a little healthier with their snacks.
Yeah, exactly.
Healthy snacks. Hey, Dr. Mel, I got a couple
Mhm.
questions in the chat already, and I just
Okay.
want to take this pause to say, um, Yvonne asks a question: can pregnant people safely get the booster?
Yes, and it is crucial if you are pregnant to get the booster, because we know that pregnancy is a risk factor for poorer outcomes from COVID-19, as are having a chronic condition like diabetes or high blood pressure or being over age 65. So yes, they not only can they should, and they should talk to their OBGYN about it.
All righty. And one other person, Jelana Cryer, asks, are there ingredients in COVID booster shot that can cause or lead to health issues in the future?
None of the research to date has borne that out. Now, we do know that there is especially in young males, young men, that there is a slightly higher risk of heart inflammation with the vaccine. But that risk is much, much lower than the risk of the same heart inflammation from getting COVID. So if you're weighing the risk and the benefit of getting the vaccine, it makes much more sense to get the vaccine than to get COVID, because the vaccine can provide protection by boosting your antibodies, etc. Um, Other ingredients, no. The number of ingredients are very simple and very few, and none of them have been linked to side effects down the line or concerns down the line.
Okay. All right. And there you have it. So, hey,
All right.
I guess that's it for us.
All right.
Right there.
So we're now going to do our what y'all think this week.
Oh, we do have I forgot all about it, and we have to go. I mean, I
We want to
forgot.
know what the people's them think. We want to what y'all think.
Exactly, Dr. Lindy. It's amazing.
It's
It tickles
amazing.
you every time.
So the what y'all think this week is there was a new study that came out that shows that aging happens at certain ages. It's not like you just gradually start to go downhill. And the key ages are 44, 60, and then a separate study back in the day showed 80. So we want to find out from our audience what y'all think. Have y'all experienced, for those people who've gotten to those ages in our audience, did you notice that your body started to,
What
slow
are
down or
what are
not
the
repair
ages
as
again, Dr.
well? Or
Mel? What are they?
44, 44,
Okay.
60, and 80.
Okay. I can honestly say at 80, uh, I didn't notice any change.
Yeah, okay.
Definitely after 44, for sure.
44, 44, 44 was cool. I mean, things did start to just
I didn't start
wheels
wearing
fell off.
glasses until my 40s. So
You
I
what?
I didn't start wearing glasses until my 40s.
Wow. I didn't have a
Ah,
beard until my 40s.
Mm.
okay. Well, that's a major change.
Somebody
And
put
for
heightened
me,
sexual feelings at 44.
good for
Okay.
them. That's
Yeah,
fantastic.
A
yeah,
growth
somebody
spurt,
said
all
60
right.
for sure.
Growth spurt. Well, for me, I think my 40s were cool. I didn't really start to get to anything until I got, you know, fat past 50. 50 was the age for me. So
50?
Mm.
Wow.
50 was the age for me. The 40s were smooth sailing. So,
Okay.
all
Okay.
right. Well,
All right, y'all tell us
I
what
will
y'all
see you
think.
all a little bit
Tell us
later.
what you
Yeah,
think. Put it
put
in
it
the
in the
chat.
chat. Let us know. And we are going to move into the main event, which is this election season, y'all. Health is actually on the ballot. And even though it might not be featured in the debates or at the top of the news headlines, whoever gets into the White House after November will have very different effects on the health of on the policies regarding how we as communities get better health, or individually, whether we're able to afford health care and what our health care rights will be. A whole group of issues regarding health and wellness are on the ballot. And so, to talk about those tonight, I am super excited to welcome Dr. Lindi Randall-Hayes. She is a board certified emergency medicine physician trained at Howard University Hospital, and she now lives in and practices in the Indiana and Illinois area. She has a public health focus that has led her to partner with multiple local, regional, and state and national legislative organizations around health and health policy and communication around emergency medicine issues. She also provides health updates on television and radio. She's worked with the Army Corps of Engineers as a medical director of field hospitals throughout the pandemic. So she has this wealth of knowledge that she draws from to talk to us about this subject tonight. So welcome, Dr. Lindi. Thanks for joining us.
Thank you, Dr. Mel. It is so great to see you, and thank you so much for inviting me. And I love, love, love your show, and I love the What Y'all Think. Yes.
Well, good. Well, let's jump into it because we have a lot of stuff, to talk about that I would love for people to know when they go in that ballot box, what they need to be considering. So the first is one of the main topic that I think has been, bandied about, and that's the Affordable Health Care Act. And wanted to just, if you could just give us a brief overview of what the Affordable Care Act is. People know it as Obamacare. Oftentimes, the Democrats want to keep it, the Republicans want to repeal it. So tell us a little bit about it and why is it such a sort of political football?
Well, Obamacare, that is the claim to fame of our forever president. And it was basically a legislative way to expand and broaden healthcare opportunities and health equity and healthcare access to more people. So basically, before the Affordable Care Act was enacted in March of 2010, we passed the 14-year mark. At that time, there was approximately 16 to 17% of Americans who did not have health care at that time, prior to the Affordable Care Act or Obamacare being enacted. So after the Affordable Care Act was enacted, also known as, again, Obamacare, we'll just call it Obamacare for the sake of our audience here. After that, the uninsured went down to about 6 to 7%. So it provided an opportunity again for more people to have an option to access healthcare, accessing healthcare, thus increasing health equity, thus decreasing morbidity, death, and illness rates among those in our community, and providing greater access to our physicians, our healthcare providers, etc. So it has been attempted to be repealed and overturned numerous times. I lost the number. I've lost count in terms of how many times there have been congressional legislation that has gone forth to try to repeal it. But as we saw on that great debate night that all the three of you all watched together, and that debate watch parties across the country saw, there is no plan to replace Obamacare or the Affordable Care Act at this time. There's concept of a plan, but there's nothing in place.
Right. Yeah, I think many people heard that. Yeah. So just so that everybody understands, the way that the Affordable Care Act extends coverage is they have these marketplace plans that if your income doesn't allow you to purchase a health plan outright, you're able to basically get subsidized to be able to purchase health insurance on the marketplace. And the other way that it does it is it extends Medicaid eligibility, which is the program that's run by the states for people who are at even lower incomes than those who would qualify for the marketplace plans. And it extends the eligibility for Medicaid, but the states have to buy into it. The states have to agree with the federal government, yeah, we're going to extend Medicaid. And unfortunately, in many southern states or Republican-run states, that didn't happen. So, but in those states, I know, for example, in DC, when they accepted the Medicaid expansion, basically 98% of people in DC have access to some health plan, whether it's Medicaid, Medicare, private insurance, or on the insurance exchange. So what changes might we expect in the future to the Affordable Care Act? Are there any plans to expand it or change it in any way that you know of?
Well, to your pointed explanation about the increase in the marketplace, basically Obamacare or the Affordable Care Act being kind of a conglomerate of government-run insurance as well as private insurance, allowing a marketplace, allowing the kind of the coexistence between the two. Basically, what the two options or the two differences in philosophy in terms of how to expand healthcare to more people would basically get rid of, the attempt is to get rid of the government portion of the Affordable Care Act because it is considered a entitlement program, a program that costs the country, billions and billions of dollars. And so the overall gist and plan would be to eliminate the federal portion. In terms of how to expand it, on the other side, looking at our choices in November, expanding it on the other side as opposed to limiting it or dissolving it altogether would be to your point, to go to those states that have not expanded Medicare options, some of those southern states. Some of those states that we actually thought were not going to expand the Medicaid option, for example, did. So Indiana was one of the first to one of those first quote unquote red states to actually accept the expanded Medicaid option. So it really would be a messaging, a broadening of the legislation to increase the education throughout the country for those states that have not expanded Medicaid. And from what I am able to read and to kind of gather from all the information is that would be the primary way and route that we would use to expand Obamacare and also to decrease those uninsured even further from the 6 to 7% down to less than that.
Right.
So probably one of the primary ways.
Now, one thing we haven't heard about this election cycle is Medicare for all. Nobody's talking about that. But what is that, and how is that different than the Affordable Care Act? And how does that sort of figure into sort of a social philosophy of whether healthcare is a right versus a privilege?
So universal healthcare, the Medicare for all, is not what Obamacare is. I think that early on in the conversations, I think it wanted to be, looking at some of the other advanced countries throughout the world, Canada, Ireland, Italy, those places have universal healthcare coverage. So basically for a simple explanation, universal coverage is going to be, or Medicare for all is going to be an entirely government-run healthcare system and provision. And so the private healthcare and private healthcare insurers would not have or play the role in reimbursements, et cetera, that they do currently. And so again, the thought was that for compromise, the country, the United States that is, was not quote unquote ready for universal healthcare. Although we know that there are sections of our community, of our colleagues, there's a whole organization called Physicians for a National Healthcare Plan. There is still a push for universal healthcare or Medicare for all, but it is something that's going to require significant further discussion with private insurers, healthcare, all of the intertwining between healthcare providers and insurers that currently exist. How would we deal with some of those pieces if you have healthcare providers and physicians, et cetera, whose companies are intertwined financially and in terms of healthcare delivery with the actual reimbursers? So it's going to be an interesting conversation. But as some of this healthcare, some of the health insurers continue to kind of expand their role into actual healthcare delivery, I think that discussion is going to get more and more difficult, unfortunately.
Yeah. Yeah. Well, we'll see. But another piece of that access to healthcare is also access to medications. So, the Inflation Reduction Act that recently, meaning recently in the past year or so, was passed, influenced prescription drug prices. How did it do that? And what other steps are needed to ensure that medications remain affordable?
So one of the things that we need to do is we need to advocate as physicians, as providers, as a medical community, that the Inflation Reduction Act not be overturned. So it was passed in January or so of 2022. And when we hear legislators talk about, $35 cap for insulin, that's what that is. That's what most people know. They just don't realize that it's within the Inflation Reduction Act, which also has a lot of other things in it. So it has environmental protections, and it has things about energy conservation and things about the environment and so on and so forth. But and all those things are we can connect the dots to those things back to healthcare.
Back to healthcare, absolutely.
Absolutely. But in terms of specifically medication costs, it allows Medicare, for example, to negotiate healthcare, prescription costs. And so it removes some of that monopoly from companies in terms of certain brand name prescriptions. And then also what the Inflation Reduction Act does as well is it decreases the amount of time that a manufacturer of a particular medication can hold on to that patent or that brand name, for et cetera, without it becoming available in a generic or in a more affordable form, which is what we need to understand is going to help healthcare delivery, and it's going to help to increase access to medications and insulin and all those things that may have been deemed high or advanced medications. The Inflation Reduction Act is built in it to decrease that time, increase your opportunity to access to the medications that you need.
Right, and the cost of basic things like insulin or blood pressure drugs, if people are skipping their medications so that they can eat or so that they can pay rent, then that they're just going to end right back up in the hospital. So what's the point of, the Affordable Care Act or anything else if you can't afford to stay healthy, right? Because you can't afford the medicines. So I think that's a really, really crucial point, that if, who has a plan to help to address the cost of prescription drugs, that's very important. And looking to understand, which candidates are really emphasizing that.
Yeah.
And now the biggie, the one that gets all the headlines, and that's reproductive health. And, with the overturning of Roe versus Wade, what are the most pressing concerns that we need to be thinking about regarding reproductive health care access in the United States? So we no longer have the federal protection in the court. So the decision about reproductive health care has gone back to the states. So what should we be thinking about vis-a-vis access to reproductive health care?
Oh, goodness. Like you said, this is the biggie. So just as we, talk to our colleagues and our patients and their family members, it really almost feels like the Wild Wild West in terms of the healthcare that is provided to women, and on the topic of reproduction, depending on where you live. And so I would say one of the biggest concerns is that obviously there's a variation in healthcare. So you have, some of us who we've been trained about, medicine and physiology and anatomy and all of those things. We've been training our subspecialties, et cetera. But now we are subject to the influence of legislators who know no medical training, who have no medical degrees, who are interfering with the relationship between physicians in their patients, and then their patients' private decisions. So one of the biggest things is the infringement, or almost the discrediting of experts trained in medical care for women, trained in reproductive health. And I would say probably, I mean, that's really what I would say, probably the biggest and most concerning pressing issue is the state's interpretation of what exactly is medical care. All these terms get thrown around to people, you know, abortion versus miscarriage versus there can't be a woman bleeding out in the bathroom in the, you know, or in the parking lot. That's impossible. That's not true. You know, so having people,
but we've seen that in the emergency department.
We've seen it in the emergency department in real life, and it is real. And because of the Dobbs decision in states basically practicing medicine in different ways, you know, I think about even with our Hippocratic Oath, how the Hippocratic Oath now changes depending on what state you live in and how you are able to practice. So it's really that moral, that ethical, and then the actual true clinical consequences of the overturning of Roe versus Wade. Again, that's the one that people are most passionate about and feel most strongly about in one way or another. But it's even discussed in Project 2025. It's discussed in the platforms of both major parties in terms of whether there's a protection for Roe or not. And so it's definitely something that our audience needs to, and your audience needs to consider and think very seriously about in terms of,
right.
In terms of,
yeah. And I think when we talk about, you know, it's not just a procedure, but it's also access to the medications that help you have control over whether your pregnancy is terminated or not. And there's also an issue of socioeconomic status, because those people who are have less money, less access to transportation, can't travel to another state to have an abortion procedure if they so choose. So therefore the burden falls more on those individuals who don't have the resources to go to another state or to consult a doctor out of state if their state has more restrictive laws against abortion. So it becomes an equity issue, a health equity issue, I think, when you think about it in those terms. You mentioned Project 2025. Does Project 2025 weigh in on this issue at all?
Well, it weighs in on it.
And what is Project? And you probably have to say what Project 2025 is.
So Project 2025 is the document. It's called Mandate for Leadership. And basically it is a document that was developed by an organization that is heavily aligned with the Republican Party. Approximately 100 or so of the authors of this document served in the prior administrations in one shape, form, or fashion. The Health and Human Services portion of Project 2025, because it's all laid out in sections and it's all outlined, but the healthcare portion specifically, although there is healthcare implication and topics that are addressed throughout the entire 900 pages, about 90 or so pages are specifically dedicated to healthcare reform and basically the plan to really dismantle the structure of the healthcare organizations as we know it. So the Health and Human Services, for example, has underneath it the Center for Disease Control. You talked about the FDA earlier. It also has those are the two main, National Institute of Health, for example, as well. And so the plan basically is to structure the system such that these organizations no longer have the authority to declare, for example, a public health emergency, or no longer have the authority to make recommendations, because in their words, when the CDC recommends, it becomes a you must do. So the plan is to basically remove those that power and that authority of experts to make the healthcare decisions that they have studied their lifelong committed their study to. And
so who would have that authority then?
Well, interesting. You should ask that. So it looks like those who would have that authority are those that would be appointed by the president, and they must be appointed and approved by the president, which is why there's a lot of talk about, you hear a lot about how they want to, there's a discussion of dismantling the Department of Education, et cetera. So it's not only the Department of Education, it's also even the healthcare services. Yeah, it's the Department of Health and Human Services. So there's the goal to dismantle that and have that replaced with experts who, well, not even experts, but persons who are appointed by the president. So interestingly enough, the healthcare portion of Project 2025 is written by an attorney. So nothing against attorneys. However, there's a lot of healthcare policy and discussion about actual clinical things, i.e. spontaneous abortion.
Things that people go to medical school
many years
for 4 years and train 4 to 7 years after that to be experts in. I got you.
Absolutely. So this whole section was written by an attorney. So to me, that gives me even further insight that it's not necessarily something that they want people who have been practicing for 40 years to make decisions about. It has to align with a philosophical and a theological and a personal health principles in terms of your own ethical thoughts and way that you live your life. It should not be based on that. It should be based on a structure that provides those guidelines for you.
Right. Based on science and based on evidence.
Mm-hmm.
So I can't believe I have so many more questions for you, but I really want to make sure that we get the audience asking their questions, getting clarification on the stuff we talked about. So Wayne, Lila, come on back. Please join us and let us know if there are any questions that are circulating around in the chat.
There are, Brother Wayne, you're muted.
There are a ton.
Really?
Yeah, there are a ton.
Okay.
You want to start off, Lila?
No, I'll let you go.
You're going to let me go first? Thank you.
I'll let you go first.
So, there are a lot of comments and a lot of questions, but Yvonne says, how will doctors in emergency room have an effect on women's health? Doctors would have to imagine, what would you imagine would happen to miscarriages? I hope I said that right, Yvonne.
Yeah.
It was a mouthful.
Dr. Lindi?
Yeah. Well, so basically the whole EMTALA that we were, trained up on, EMTALA, the Emergency Medical Treatment and Labor Act. So basically our two choices in November, one wants to do away with the whole being in labor portion. So whether that labor be from a miscarriage or a preterm labor or complications from medications used to initiate abortion or any of those things. So there is a plan to basically remove EMTALA, which provides and which states that emergency physicians must provide and stabilize these women. And so that's what's happening in some of these states where abortion is completely against the law. And so how it affects us depends on what state you live in, and it depends on where you practice. So completely just basically upends your medical expertise and what you are trained to do, because you may be retaliated against, or there may be some legal action because you are not communicating with the hospital attorneys and making sure that things are aligning with what they want to do. So it's creating havoc across the country.
This is bananas. These are my thoughts and not the thoughts necessarily of the producers and the hosts of this show. But this is crazy that politicians want to be all in our body. All right. Dr. Lindi, I have a question about gender affirming care. There's all this debate around it. So can you explain what it involves and why it's not only a healthcare issue, but why it is a healthcare issue and not just a political issue?
So gender affirming care is a healthcare issue because depending on what state you live in, it may or may not be covered by your insurance. What it gets into is the ethical discussion of who a person decides and who they deem themselves to be and who they've decided they're going to be sexually, and who they feel they were born as. So it interferes with a person's decision, and it transcends into, well, we don't believe in it, and so even though you have insurance, we're not going to cover it because it is against the law, or it's against the policies that we set forth in our insurance documents or under our coverage. And so it may involve what's historically been called a sex change. We don't use those terms anymore. Right. That is what it has been, called in the past. And there's a negative connotation with that when you use some of those words and some of those terms. But it is, again, another opportunity to infringe upon I believe, the rights and privileges of human beings to determine their own destiny.
So we have a comment from the Sotritionist. RDN says that's not necessarily true, talking about senators not having been informed about writing policy and not being physicians. There are 25 senators that are MDs. I just want to say we're here to correct when things are not correct. And that wasn't correct. There are not 25 senators that are MDs. There are 4 senators that are doctors, medical doctors. There are 22 representatives in the House, 6 Democrats, 20 Republicans, and that is it. Those are your medical professionals, considered your medical professionals in Congress, currently in Congress and the Senate. I want to ask this question.
I think I just want to be clear, and you were talking about the people that authored Project 2025, right?
Oh, authored.
So I'm
correct.
Yes, I just want to be clear that she was saying that a lawyer authored it,
right?
Yeah. So,
but I want to correct people who even come into the chat and say that there are 25 U.S. senators
who are doctors,
who are medical doctors.
Yeah, right, medical professionals, right?
Medical professionals, and there's a different level. Yeah, different level of training, expertise, and again, that Project 2025, they are not. That section was not written in position.
So I want to ask about gun violence and school shootings. That is a hot topic. Is there anything from a policy standpoint that could be done? We found out through this show and just our studies that gun violence is a medical issue, is a health issue. Is there anything that can be done, or anybody proposing anything from a policy standpoint that we should be demanding from the lawmakers?
And just so that you know, in some jurisdictions like DC, Washington DC, violence has been declared a public health emergency, and so there is definitely a direct connection between violence and health, right?
Right.
So, Dr. Lindi?
Yeah, absolutely. So one of the things I was reading just in kind of doing some research previously is that a statement from one of the Republican legislators said, Americans have a right to life, not a right to health care. Life, liberty, and the pursuit of happiness and freedom is theirs, but everything else is based on resources. So,
Wow.
yeah. So, and so when we talk about, gun violence and what is it that we can do when you go into the ballot box, to have an understanding that there is one choice where the options are to have background checks, be able to do a universal background checks, not just depending on where you live, universal background checks. So if you try to buy a gun in Indiana, but you have all of your maybe legal records or whatever in another state, in Illinois, for example, universal background checks would allow a nationwide search for that background. So you can't go to another state and hide. And so that is something that is one of the pieces of legislation. That's really the core of the legislation. And there's a lot of detail behind that and involved in that. But the primary goal is to have universal background checks to be able to allow the whoever is processing that for that licensure to be able to purchase a gun, to be able to see if there's anything in your background that would allow. And then red flag laws, anything that comes up as a red flag that this person should not have a gun because of either prior offenses or attempts, prior medical issues or mental health issues and things of that nature. So that's the major thing that we really want to consider when we're looking at access to guns and gun violence. There's a lot of, just like Dr. Mel said, it's definitely been declared a public health emergency, along with, we know even racism has been declared a public health emergency. But we want to, it's all these things that are intertwined that are going to affect healthcare delivery and health equity and all of those socioeconomic factors that are going to either allow our communities to thrive or not.
Well said. Thank you for that explanation.
Yeah.
Wow.
I have a question. So since the pandemic, I am especially concerned about mental health. What can be done from a policy perspective to improve mental health services so people are getting the help that they need?
Well, the Healthcare Affordability Act and the Obamacare has provision in it for mental health services, as well as Medicare, and insurers are now required. There is a mental health and wellness portion to private insurance coverage. If there is not in a person's particular private insurance coverage, there's a way to get it added on. Okay. But one of the ways that we can, and I think we've done so much better with mental health education and discussion and outreach. I think that we are really, from an informational standpoint, we have really come a long way. But we definitely want to make sure, we want to ask our legislators, where do you stand on mental health coverage in insurance, whether it is my private insurance or whether it comes under Medicaid or Medicare or coverage. How do you what is your stance on that? And I think that will tell us a lot about who do we see and who do we recognize, who really knows that mental health is important, who understands that mental health care is health care.
Right. And that's why it's so important to understand who is up and down your ballot and why primary elections are so important. Like, there's so many things that we get to as people, as as citizens of the US, we have to do our part, but we got to know who these people are that we're voting in as our council people and stuff. We need to understand, make demands. We get to do that. I feel like, I just wanted to say this. I know it's really a thing. Like, you can't even go see a dentist without being asked about your mental health, right? Like depression questions, where you are. And so I feel like that's a shift that has occurred over the last several years, that I wasn't seeing those questionnaires necessarily before going into the doctor's office. So
Yeah, and I think one of the other, I think young people have really advanced the conversation in terms of destigmatizing it.
Yeah.
But at the same time, a number of factors, because it's destigmatized, because of the pandemic, um, there's a higher demand now for mental health services. And my concern is that there are not enough mental health professionals to, to especially be matched from a cultural competency standpoint. Um, so mental health professionals coming from various communities to be able to service various communities. So I think, to me, one major policy issue is, how can we increase the number of the pipeline for mental health professionals at every level, from counselors to licensed clinical social workers to psychologists to psychiatrists, all across the board, to make sure that there are really enough mental health professionals to address the mental health, I say, epidemic of
Yes.
poor mental health that we're experiencing now, and also too because of social media and just that sense of disconnectedness that people have, especially young people. I think that's a major way that we can advocate and ask um, politicians at every level, how are you going to increase the pipeline of people going into mental health related professions?
Well, that's such a good point, Dr. Mel. Yeah.
Absolutely, because people wouldn't believe, except you, Dr. Mel, if you ask someone, what is the average wait time for a mental health patient in the emergency department if we see a patient in the emergency department and we say this patient needs to be admitted to the hospital, what is the average time that it takes that patient to actually get a bed somewhere at a mental health dedicated facility?
And just so that the criteria for being admitted generally is they're a danger to themselves or a danger to other people.
Yes, that's exactly right. So we're about probably 3 days. About 3 days.
Oh,
Some patients in the emergency department, 7 days, 10 days, and don't be a pediatric patient needing hospitalization. It may be 2+ weeks waiting for depending on what waiting, that patient being in the emergency department, waiting for proper care. And sometimes I wonder, I was like, should I just turn on my phone and just live stream this mess? Like I mean, sometimes and just send it to live stream and put it on a legislator's website, because it is truly a epidemic, and it is a mental health crisis. We are in a mental health crisis in terms of not enough providers, and that's a fact. That is currently, so that whole pipeline conversation, I don't know how quickly we can feed into that pipeline, but we are so far behind in that that space.
I have to end it there. I had to put period on it. Says, so I turn it back to Dr. Mel.
Well, thank you for keeping us on point. Thank you, Dr. Lindi. Wealth of information. Thank you for sharing with that. Remember, everybody, your vote matters. It matters across the board, and it especially matters with your health. And that's the whole reason why we did this show, to highlight that. Thank you, of course, to Wayne and to Lila for bringing us all that the audience is saying in the chat, and just for your wealth of perspective as well. Thank you, the Be Health Empowered family, for your great questions, and we'll see you next week. Until then, be wise, be well, and be health empowered.